So my talk is on the role of genetics in the diagnosis of the corneal dystrophies. And relevant to this presentation, I am a consultant for Avellino Laboratories, and I'm on the Speakers Bureau for Avellino Laboratories. So I was a member of the Academy's task force on recommendations for genetic testing of inherited eye disorders, and we published this paper in ophthalmology a couple of years ago, in which we concluded that clinicians should offer genetic testing to patients with clinical findings suggestive of a Mendelian disorder whose candidate genes have been identified. If unfamiliar with such testing, the clinician should refer the patient to a physician or a counselor who is. And this is true for almost all of the corneal dystrophies. We know the genetic basis of these conditions for almost all of them, and also they are almost all Mendelian disorders, which means it's a single gene disorder. So clinical testing is relevant and is useful to diagnose and differentiate corneal dystrophies from non-dystrophic disorders. Now, a lot of you in the room have never used genetic testing in your practice, and you're practicing high-quality care. You say, well, do I need to do genetic testing? Because I can rely on a family history. These dystrophies are almost all dominantly inherited. So if there's no family history, when I'm looking at the slit lamp, it's probably not a dystrophy. And I put it to you that that's not necessarily the case. Neither a positive family history nor reliance on characteristic clinical features are really reliable means to differentiate between an inherited and non-inherited disorder of the cornea. The only way to make a definitive distinction is with molecular genetic testing. So I'm going to talk a bit about screening of refractive surgery candidates relevant to the topic of this afternoon session, and then a bit about differentiating between dystrophic and non-dystrophic corneal opacities using genetic analysis. So the first case is that of a 43-year-old woman who presented to an ophthalmologist in Southern California interested in refractive surgery. She has worn glasses and contact lenses for correction of moderate myopia and astigmatism her whole life. On examination, she demonstrated a few subtle corneal opacities, as you see here in the right eye, that were really sort of anterior stromal, as you see it in the slit beam, but very subtle. This is the left eye. And I put it to you, unless you were really looking carefully, you wouldn't see that. And if you saw that in a contact lens wearer, you'd say, well, there's probably a little scar from a prior ulcer or abrasion or whatnot. I mean, that's fairly insignificant even if you see it. So she had LASIK surgery performed. A year later, had an enhancement performed in each eye. 4 years later, returned to the surgeon complaining of decreased vision in each eye. And I don't think I need to highlight the area of abnormality here. This is the left cornea. Significant exacerbation of the opacities here in the left eye and in the right eye. And you can see in the thin slit beam, these opacities are almost all confined to the lamellar interface, and that's seen very well here on the OCT image of the right eye and of the left eye. So this tells us this is not the natural course of this disorder. Clearly, this is an acceleration of these deposits, which is, as you see here, nearly all of them are confined to the LASIK flap interface. So this is surgical-induced corneal disease. Second case, this is a 54-year-old Chinese gentleman in San Francisco interested in refractive correction of moderate myopia. This is not Dr. Bansel's patient. Clarify that right now. He's been an RGP wearer for moderate myopia, diagnosed 10 years previously with old corneal scars in each eye. He had a pre-LASIK screen. It's not clear from the notes that I have whether it's an MD or an OD, but it was an eye care provider who diagnosed him with old corneal scars due to hard contact lens abrasions with inflammation. Family history of diabetes and renal cancer, no family history of ocular disease. So the patient had LASIK performed in each eye. On post-op day number 1, the co-managing optometrist diagnosed the patient with corneal scars versus snowflake corneal dystrophy. He came back a week later to either the surgeon who performed the surgery or his co-managing optometrist, who again diagnosed old corneal scars. Highlights the fact that you and I as ophthalmologists can see the same thing in the same patient and interpret it differently. And if you interpret this incorrectly, you have a big problem. 2 years post-op, the patient came back with a big problem, decreasing vision in each eye. And like the first patient here, again, the patient went from a few little opacities now to opacities filling most of the central cornea, just like in the first case, confined to LASIK flap interface, telling us these are not naturally occurring deposits. These are induced by the LASIK surgery in that right eye and here in the left eye, We see the same thing, significant exacerbation of the deposits. These are not the only patients I've seen. There's another patient here from Colorado. Had a few fine opacities in the cornea, had LASIK. Here she is 4 years later, dense stromal opacification. Guess what? In this case, the opacities are not just on the stromal bed. So if you try to do additional ablation, it's not going to work. They're on the underside of the flap as well. So the first case has had both flaps amputated. This case has gone on to bilateral penetrating keratoplasties. So not good outcomes in these cases. As we all know, once you do a graft like this, it's going to come back again. Here's the cornea from that patient you just saw, again showing the opacities along the interface in one probably naturally occurring dystrophic deposit in the anterior stroma. In all these cases, in my laboratory, we performed screening of the TGF-beta gene. Again, this was before we had a commercially available test. Granular corneal dystrophy type 2, also known as Avellino corneal dystrophy, is associated with this mutation right here in this portion of the gene. So the normal DNA sequence, and each of these patients had this DNA change. This exacerbation after LASIK can occur with any of the TGF-beta dystrophies: lattice, granular type 1, granular type 2, Rice-Buchler, Thiel-Behnke. The reason why most, or if not all, the reports are with this is because this has the latest onset. This condition can be missed even by a very good clinician in somebody who's well within the age range for ketorefractive surgery. That's why this is the one that we're most concerned with, but this condition can happen after any of these TGF-beta dystrophies. So what are the indications for TGF-beta screening prior to ketorefractive surgery? Well, presence of unexplained corneal stromal opacities. Like in that case I showed you, the second case. Had opacities, somebody said scar, somebody else said dystrophy. You don't know. If you don't know, you better know if you're considering ketorefractive surgery. Individuals under age of 40 years with Korean or Japanese ancestry. We just saw a slide that shows the incidence in Korean population, whether they're in Korea or in the United States, about 1 in 875 individuals. That puts it probably about twice as common as keratoconus. In Japan, the incidence somewhere around 1 in 1,100, something like that. Again, more common than keratoconus. So I think you should really be screening these patients. Family history of a TGF-beta dystrophy. This is a no-brainer. If you do ketorefractive surgery on somebody with a family history of a corneal dystrophy, without doing genetic testing first, you're going to be putting yourself at significant risk and harming your patient potentially. Family history of corneal transplantation for unclear reason. I think every ketorefractive surgeon should have a question on their questionnaire about anybody in your family had a corneal transplant. Many times, of course, you know, and I know, you don't get a very clear history. If you can't get a good idea of what that transplant was done for, you should really strongly consider doing genetic testing for the TGF-beta dystrophies. It's easy to do, as we've heard. It's performed with a buccal swab. Many times a technician in your clinic can do it, or you can do it yourself very quickly. The report is very clear. There's no question in this case of mine, patient's heterozygous. This is a patient who is not a candidate for ketorefractive surgery. Third case, 39-year-old female attorney. You know where this is going. Presented for a refractive surgery evaluation, and she's not a friendly attorney. RGP wearer, she's wearing monovision, right eye for distance, family history, unremarkable. On examination, sort of a moderate myopia, low astigmatism, pachymetry, normal in each eye. On examination, the slit lamp, the only thing of interest was this little change here in the corneal endothelium, a band in the endothelium that looked reminiscent of posterior polymorphous corneal dystrophy. Specular microscopic imaging, though, of the endothelium showed good endothelial cell count in both eyes. So she had topography performed, showed a sort of unremarkable topography in the right eye with about 0.4 diopters of astigmatism, left eye 1.2, also with the rule. So she has normal topography, normal pachymetry, endothelial change in one eye, but normal endothelial cell count. How many people here would hesitate to do refractive surgery? Why? Well, if I said the endothelial cell count, though, was good, just that one isolated area was of concern. I'm setting you up. You know you're in this room. But I mean, think about it. If all of us in practice, we think, why would we not do it? She does have a PPCD, but you would explain to her you may have a chance of endothelial problems down the road, but you could consider a surface treatment, let's say. So she went on to have ketorefractive surgery and bilateral ectasia. She's undergone cross-linking in Canada because she can't have it done in the United States. Why did this patient develop ectasia? She didn't have any identifiable risk factors. Her Randleman score would have been 0. We do not too old for Pentacam. Renee wants Pentacam. So in this case, the problem is because her doctor doesn't read the literature. Nobody reads the stuff I publish. Classification of posterior polymorphous corneal dystrophy as a corneal ectatic disorder following confirmation of associated significant corneal steepening. As we learn more about the dystrophies, we learn, at least in this case, that this is not just an endothelial dystrophy. This is a corneal ectasia. These patients have abnormal expression of the ZEB1 gene, not just in the endothelium, but throughout the corneal stroma. So most of these patients, in our experience, have very steep corneas. They'd be screened out during ketorefractive surgery. But those who don't have steep corneas, like this patient, still have abnormal corneal physiology. And if these patients, I think, should not have ketorefractive surgery, even surface treatments. So indications for screening this ZEB1 gene, the presence of unexplained corneal endothelial opacities, family history of this condition, corneal ectasia, or corneal transplantation for ectasia or non-Fuchs corneal endothelial dystrophy. Again, if it's not clear what's going on, abnormal endothelial changes, should do genetic testing. So now, differentiating between dystrophic and non-dystrophic corneal opacities. Here's a gentleman I saw a couple years ago from Arizona. 65-year-old man with slowly progressive decrease in vision over the previous several years, no history of ocular trauma, no history of recurrent erosions, no family history at all of poor vision, corneal transplantation, or any other disorders. Right eye, you see in the cornea a few sort of branching opacities here on the retroillumination against the IOL, sort of a stippled appearance to the cornea. Another image of the right eye showing the branching opacities that were diffusely distributed. Again, here you can see very clearly a couple of these branching opacities. These were at all levels of the corneal stroma. Left eye, again, showing more coarse branching opacities, and here higher magnification. So what condition do we think this is? Lattice corneal dystrophy, correct. Well, we screened the TGF-beta gene. Same location as where we see Avellino dystrophy, we find the mutation for lattice, no change in this patient. Now, there are lots of different mutations throughout this gene associated with lattice. We screened for those and didn't find any. So now what do we do with this patient? What we need to do is send him to an oncologist. And he was diagnosed with monoclonal gammopathy of undetermined significance. Anytime you see what looks like amyloid deposition in the cornea in a patient without a family history, who's only had decreased vision for 5 years and he's 65 years old, no recurrent erosions, that's odd. Anytime a clinical picture just doesn't seem right, you need to do genetic testing. If it's positive, you're done. If it's negative, they must go on to an oncologist to rule out a systemic amyloidosis associated with underlying malignancy, as is the case in this patient. Case number 5 here, 50-year-old female, seen at UCSF recently, actually, just a couple months ago. Referred for evaluation, a 3-year history of increasing peripheral corneal opacities, no change in vision, no ocular discomfort, no history of prior corneal infection, no family history of any corneal disorders, but does have 2 sisters with early onset AMD starting in their 40s. So here's the image of the right eye showing those opacities that really were confined to the peripheral cornea. Left eye, almost a mirror image. What do we think this is? Looks like granular dystrophy type 1, correct? Do we have a test for granular dystrophy type 1? Yes, remember the Avellino test tests not just for granular type 2, but all of the TGF-beta dystrophies. So in this case, did OCT imaging showing these opacities confined to the subepithelial zone. Here's the family pedigree. She has 4 siblings. Nobody's affected. Again, odd. It's a TGF-beta dystrophy, but no family history. Genetic testing, in this case, excluded type 1 granular dystrophy. She had no mutation here. And type 2 was also excluded in this patient. So, what did we tell the patient? You need to see an oncologist. One day before this meeting, on Wednesday of this past week, I asked her ophthalmologist at UCSF what was the result. Patient has chronic lymphocytic leukemia, just diagnosed with it based on this. So again, you're not going to see many of these patients in your practice, but when you do, genetic testing is mandatory for these patients. And this is a paper we published in Ophthalmology just about 2 months ago on this condition. It's called periproteinemic keratopathy, where you have these myeloproliferative disorders associated with corneal opacification. One of the cases looked a bit similar to the case I just showed you here, this patient from New York. So the last case I want to show you is a young boy from Atlanta who I saw a few months ago, referred by Barry Lee. Many of you may know Barry. 8-year-old boy with a history of severe photophobia since 1 year of age, otherwise healthy, had an EUA at age 2, and Dr. Lee, a well-known corneal specialist, diagnosed with Meesmann corneal dystrophy, but was odd that there's no family history, and Barry examined both of his parents. Again, a highly regarded corneal specialist said neither parent looked affected with what we presume to be an autosomal dominant corneal dystrophy. On examination, the patient had findings that looked like Meesmann's, with these diffuse epithelial microcysts, but some sort of funny linear opacities in the epithelium as well that didn't quite fit with Meesmann dystrophy. Here's the left eye showing a similar pattern of coarse PEK, as well as these linear opacities and these little clear epithelial microcysts. An example here of another condition associated with a known mutation in 2 different genes. So I examined mom, who had a clear right cornea, clear left cornea. Both parents, fortunately, came with him from Atlanta to Los Angeles for examination. Father here had a clear right cornea and a clear left cornea. So neither parent affected. Again, like the TGF-beta gene, we know the genes that are associated with this condition. And like the TGF-beta gene, the mutations are typically clustered in just 2 different parts of these genes. So I screened those genes in this patient, and here's the individual does not have a mutation in this gene. In the KRT3 gene, no mutation in exon 1, but lo and behold, did have this change. This is actually what's called an indel. A portion of the DNA sequence had been deleted and a different portion inserted. So in this case, this is an indel associated with Meesmann corneal dystrophy. The father and the mother both did not have that change. So for those who are snickering, you're thinking, well, that's not the dad. The kid looked like the dad, but we did confirmatory paternity testing that is the biologic father. So this is a confirmed spontaneous mutation associated with autosomal dominant dystrophy. This has been reported with multiple dystrophies. It can happen with the TGF-beta dystrophies as well. So indications for genetic analysis and diagnosing corneal opacities: absence of a family history. Somebody looks like they have a lattice dystrophy, granular, Meesmann's, whatever, but there's no family history. Think about doing genetic testing. They have absence of associated symptoms. The gentleman from Arizona without recurrent erosions who looked like he has lattice. Lattice patients always get recurrent erosions. So you see that? Think about doing genetic testing. Atypical clinical features: late onset, unilateral or markedly asymmetric involvement. Molecular genetic testing provides a rapid, inexpensive, non-invasive, definitive means, probably the most definitive means, of identifying individuals at risk of significant complications following ketorefractive surgery, as we saw exacerbation of any of the TGF-beta dystrophies or ectasia in the patient with a posterior polymorphous corneal dystrophy. And a useful means of differentiating between dystrophic and neoplastic corneal protein deposition, differentiating between dystrophic and degenerative corneal opacification, and diagnosing suspected dominant corneal dystrophies in the absence of a family history. I acknowledge the folks in my lab who have done some of the genetic testing that I just presented to you, and I thank all of you for coming to our lunch symposium.